Thank you. I'd like to take the opportunity to thank the organisers for giving me the chance to present this morning and for you for attending at this early hour on the final day of ASMS. I'm presenting work, but obviously I didn't do the work myself. The work was done by a team that are shown here. And that team comes from 3 institutions, from University College Dublin, from Trinity College Dublin, and colleagues in the Dana-Farber. And just for clarity, they're colour-coded there. So you can see that it's an evenly balanced team of collaborators who've been working on this project for a number of years. And our intention really has to be to try to connect basic lab scientists with clinicians in terms of maximising their understanding of the challenges that we face in moving towards success in translational research. So I'm not sure I would regard this necessarily as success, but certainly we hope that it's en route to success. So what I'd like to do is and it's going to be in the arena of prostate cancer, and I'd like to present prostate cancer, but from a patient perspective, because I think we learn a lot by doing that. And from that we'll identify, I hope, a key issue in prostate cancer. I'll describe briefly the aims of the study and then move on to describe what we've actually done and reach some conclusions and highlight some of the challenges we think we face as we try to move forward. I'm conscious of time, and so I'm going to move fairly rapidly through this, but I am going to spend a bit of time trying to lay the background. So I'd like you to imagine this scene. This is Harry. He's in his mid-50s, and he goes to his clinician because he's not been particularly well. His clinician persuades him after a period of time to have a full health check because he hasn't been to see him for at least 10 years, typical of many men in their mid-50s. Sorry, I've gone the wrong way here. It doesn't seem to be moving forward. Let me try again. Yeah, I'm clicking the left one. It's decided to change directions. Okay, we're going in the right direction now. And so the test is done, and Harry gets the results. And it's clear that his blood pressure, his urine test, his heart assessment, his lung and hearing and eye function are all perfect. He's got 20/20 vision and everything's okay. Has a full blood test, his cholesterol and glucose levels, again, his liver and kidney function, they're all perfect. But because he was over 40, Harry had a test done called the PSA test. And his PSA came back as 12.2 nanograms per mil. And he didn't know what PSA was, and he certainly didn't know what nanograms per mil meant. But essentially this means that he's potentially at risk of having prostate cancer. And he asks the question, what now? And the next stage is to have the prostate palpated by using a digital rectal exam. That's where a digit is inserted into the rectum and the prostate's palpated. For Harry, that comes back as slightly abnormal. And the next stage is to have a biopsy, in which a needle is inserted into the prostate through the rectum, guided by ultrasound, and 12 cores of the prostate tissue are taken and scored by an expert pathologist on a Gleason scoring system that grades from low to high, Gleason 3 to Gleason 5. And so the result for Harry is that he has a PSA of 12.2 nanograms per mil, his DRE is abnormal, and he has a Gleason score of 3+4. The conclusion of that is undoubtedly that he has prostate cancer. And a few weeks ago, he was perfectly asymptomatic and a perfectly, as far as he was aware, fit and healthy mid-50-year-old man. And now, of course, he asks with a little more urgency, what next? And he has a fundamental, important, life-changing decision to make. He could choose to have the prostate removed by radical prostatectomy, and that's done increasingly by robotic surgery. So here's the surgeon here, the patient is over here. He could have radiation treatment, and increasingly there are advances being made in that in terms of directing the dose of radiation to minimize the complications of irradiating organs and tissues other than the prostate. Or he could choose not to have those and instead undergo active surveillance, in which he's monitored for disease progression by repeat PSA testing, possibly repeat biopsies every year, and potentially imaging, multiple parametric MRI imaging. The consequences of these treatments are significant. So the comorbidities are urinary dysfunction and bowel dysfunction, and many men will experience those. There's often loss of erectile ability, and so erectile dysfunction with consequent loss of fertility. And there are significant side effects of the chemical treatments that are then used to treat prostate cancer. If he chooses active surveillance, there are some consequences of that as well. He's likely to have significant anxiety about having and living with a cancer inside him, and it's likely that he will come under significant external pressure to have one of those treatments. because after all, he has a cancer. He's not alone. 1 in 6 men will get a diagnosis of prostate cancer, so that's about 14% of men will be diagnosed with prostate cancer at sometime in their lives. And if you include significant others, that means that prostate cancer probably affects something like 1 in 2 or 1 in 3 individuals in this room it will affect at some stage. In 2013, there are estimated to be almost 3 million men in the US alone living with prostate cancer, and these are the numbers that are diagnosed each year. See if I can move this down here, with prostate cancer. Ireland's a small country. It's just over 3,000 men. In the USA, it's closer to and probably greater than 360,000 men every year diagnosed with prostate cancer. And this is taken from the Wall Street Journal just under a month ago, which shows that the PSA tests, there are 30 million PSA tests per annum in the US. About a fifth of those report an elevated PSA. There are about 1 million men who go on to biopsy, and in those 1 million men, the biopsy finds prostate cancer in about 180,000. It misses prostate cancer, though, in about another 180,000. So the biopsying process is not, in many ways, not very ideal. So prostate cancer, the issue is that if you screen 1,000 men with that PSA test, about 100 to 120 are going to get a false positive, about 100 will get a diagnosis of prostate cancer, at least half of those will be treated and suffer the consequences of that treatment, those complications. 4 or 5 men will die from the disease, and by screening those 1,000 men, you may have saved perhaps 1 or 2 lives. And so the reality is that most men die with this disease rather than because of it. Greater than 60% of those who are diagnosed with the disease early could have active surveillance, but currently they don't. And overtreatment, not just the consequences for the individuals concerned, but in terms of financial consequences, is a huge burden. So in the US, it's estimated to be at least $3 billion each year. And recent data that's come out of a number of studies suggests that active surveillance would be just as effective. So what decision does Harry make? Well, that decision is made using a number of risk stratification tools, but the Gleason score is still the most important factor in helping to make that decision. And about 80 to 85% of all prostate cancer biopsies undertaken will report a Gleason score of 6 or a Gleason score of 7. And this is a combination of 2 scores that the pathologist uses. This is the most dominant form of the pathology, and this is the second most. And so we can see that in some cases men have predominantly Gleason grade 3, but some Gleason grade 4. Others have some predominantly Gleason grade 4, but some Gleason grade 3. Of course, what happens to Harry might also depend on where he is, because in the in Europe, the European Association of Urology would rate Harry as intermediate risk from the disease, and active surveillance for him in Europe currently, according to these guidelines, is not an option. Paradoxically, in the US, where there's more overtreatment of the disease, he's classified as intermediate risk according to the American Urology Association guidelines, and active surveillance is an option. But as I've indicated, many men don't get active surveillance. And the problem's complicated further because not all 7s are equal. So our collaborators, part of the TopCat consortium, analyzed over 800 biopsy and prostatectomy samples, and were able to show that there's a 3-fold increased risk if Harry had Gleason 4 plus 3 rather than 3 plus 4, the 3 plus 4 that he does have. And so that's been confirmed in a more recent study in which 26,000 men have had their Gleason scores analyzed and compared with biochemical recurrence. This is progression of the disease. And you can see again there's about a 3-fold increase in progression in men who have 4 plus 3 versus 3 plus 4. And that's led to new guidelines for grouping the diseases, so to change this Gleason scoring system. Or not change the scoring system, but to change the reporting of that scoring. So Gleason 6 is now 1 or less is 1, 3 plus 4 is 2, and 4 plus 3 is now group 3. So they've been separated into 2 groups to represent that difference. So this is the new grading system, which I've just previously described. And this is what it looks like in practice in terms of a pathologist. And so you can see that, as you'd anticipate, this isn't a definitive switch between 3 plus 4 and 4 plus 3, and it's actually challenging to do that. So there's a dotted line here, but there's a continuum of the pathology at the tissue level. So the key issues are that too few men are diagnosed with prostate cancer and put on active surveillance, and that results in overtreatment. And defining 3 plus 4 plus 4 plus 3 versus 4 plus 3 for the pathologist is very challenging. And it's clear that better prognostic tools are required. And that was highlighted in a Nature article at the end of last year, because active surveillance is becoming recognized as a better treatment option for men with prostate cancer. But the problem is that the current tools for selecting men to go onto active surveillance are not as good as they could be. And so it would be safe, active surveillance, and very safe if there were better tools for selecting patients who are on prostate cancer. So our aims were to identify genes and proteins that are differentially expressed between Gleason 3 and Gleason 4 regions in the prostate. And that might enable us to discriminate between group 2 and group 3 to a better extent. And to try and understand if there are differences between gene and protein expression between epithelial cells and stromal cells in G3 and G4 regions. And we've tackled that by doing comprehensive transcript by RNA-seq analysis and protein profiling. And I'm only going to have time to talk about the protein profiling. So we've used laser capture microdissection to isolate discrete tumor regions of interest. And this just shows a project timeline. I don't have time to go into it, except that the first half of this project timeline was really establishing and optimizing the methodology required to take tissue sections frozen for the proteomic analysis and FFPE, adjacent FFPE sections for the RNA-seq analysis, and take those sections, isolate regions, epithelial and stromal regions, and characterize proteins by label-free LCMS. And you can see that we've achieved here around 2,000 proteins being identified, 2,000 to 3,000 proteins. So the remaining half of the project really has involved taking tissues from a sample resource in the Dana-Farber, the Gelb tissue resource, sectioning those and taking 15 sections, 15 or 16 sections from each tissue, and doing those as serial sections, and then taking sandwich sections and subjecting them to H&E staining and analysis by pathologists, taking the sections from the US back to Dublin and doing LCM, and using telepathology, so taking the images acquired in the US that have been annotated by the pathologists and using those to guide the laser capture microdissection in Dublin. That has resulted in the isolation of significant numbers of cells and the protein from them. And we've chosen to use one DSDS page to concentrate those, do in-gel protein digestion, and then proteomic profiling. And so this is the consequence of 6 weeks continuous sectioning and around 3 months of LCM to get material from these discrete regions from a total of 8 patient samples. And so this was an N equals 4 patients and 8 samples from those patients. And so this just outlines the recovery. And you can see that these are tiny amounts of protein material that are recovered by this process. And what we've done with that material then is subjected it to label-free LCMS. And this shows a sort of a snapshot of the data. These are the technical replicates. And so we always run technical replicates. And you can see that we can, on technical replicates, then we have really high reproducibility. These are the numbers of proteins. And although this isn't scaled, what this should be able to depict is that there are a large number of proteins overlapping between the individual samples from those regions. And we can use principal component analysis and hierarchical clustering and show that that segregates to some extent the Gleason 3 epithelia and the Gleason 4 epithelia from the Gleason 3 stroma and 4 stroma, and there's segregation between those groupings as well. So essentially it means that within this panel of proteins that we're identifying, a few thousand proteins, there are proteins that discriminate those different regions, both epithelial and stroma, and Gleason 3 from Gleason 4. And so the next task, I suppose, is to mine that data and identify the number of proteins that are changing significantly, and we've done that both at the individual protein, the ANOVA level, and then map those significant changes onto molecular pathways. And you can see that many of the molecular pathways are the ones that we would anticipate, both being up and or down regulated, but it's really interesting to see that they're differentially sometimes regulated between Gleason 3 and Gleason 4, and this is just showing the data for the epithelial stromal. Here we have stromal, and obviously epithelial stromal. And so we've been able to map that. And there are some interesting observations in there that I don't really have time to drill down into. But essentially now what we did was we took 3 individuals and asked them to analyze the data and to put that through their data analysis workflow that they would normally use. And they came up with a priority list of 29 proteins. And that was based on some indications on network analysis. It was based on some indications of previous recognition that these proteins play an important role in prostate cancer. The protein verification then, because what we'd like to do is be able to determine whether those proteins change by using immunohistochemistry. And so we've taken that short list of 29 proteins and we've used it to search the protein atlas. And the protein atlas is a repository of antibodies, over 25,000 antibodies against over 17,000 proteins that have been mapped to a large number of human normal tissues, but also a number of cancer tissues, including prostate cancer. And what we identified from this process is that there are 26 proteins available for potentially with antibodies available to them. And we then did a second round of prioritizing. And so then to move forward in a pilot, we've selected 4 proteins for immunohistochemistry evaluation that had been shown through this process of prioritization to have antibodies available in the Human Protein Atlas and those antibodies to demonstrate staining of the cognate protein in prostate cancer cells. So this was using the resource of the Human Protein Atlas to prioritize the work that we were doing. The 4 proteins that were selected are listed here, and I don't have time to go into the details of them, but some of them, like nucleolin, are already used as cancer markers. And then we subjected those 4 proteins to immunohistochemistry staining using TMAs from about 130 patient samples. And those TMAs, they represent significant challenges in themselves, and very often the TMAs, if they're not of the highest quality, it's difficult to extract data. But what's happened here is that the staining has been done in a hospital path lab by a trained clinician, pathologist, and this scoring has been done by a research scientist completely blinded. And what's that shown when we unblind it is that for some of the proteins, we see that there is an increase, and that corresponds with the data that we had from the LCMS. And then for other of the proteins between Gleason 3 and Gleason 4, there isn't an increase, at least in this pilot immunohistochemistry study on tissue microarrays. So to conclude, I think coupling LCM to advanced LCMS has supported the identification of proteins that are differentially expressed in prostate cancer tumor regions of interest, both epithelial and stromal. A subset of the proteins have strong prior association with prostate cancer. That provides some sort of authenticity and unbiased positive control, if you like. The protein data set is possibly one of the largest acquired for prostate cancer tumor regions of interest, and it will be publicly available when we've published this work. Protein Atlas, I think, for us has been very effective in fast-tracking those verification studies and identifying pathology-grade antibodies for use. The initial TMA staining of 4 proteins has provided verification of protein expression changes for 2 of them, and a panel of proteins have been identified and prioritized, and some of them could potentially be used as markers to discriminate 3+4 and 4+3. And so that is probably the most important conclusion of the study, and one that we would like to try and progress, because that's the one that has potential clinical utility. Of course, I've already indicated that using TMAs for verification is challenging. We haven't talked about anything about the RNA-seq data and combining the proteomic data with RNA-seq, and I think that probably requires significant skills that we possibly don't have. And I think possibly the greatest challenge of this is developing strategies for interpreting these data sets and designing further studies that maximize the opportunity to realize our clinically focused aims, and that's going to be very difficult, I think. So I'd just like to acknowledge those in the Conway Institute, those in St James's Hospital, so that should say Trinity College Dublin, the Dana-Farber, Lance Liotta, who assisted us with the training in laser capture microdissection, and the funding agencies who made this possible. And of course, finally, to the patients themselves, who in these and other studies have supported everything that we do. And thank you for your attention.
Any questions for the audience? We have time for a couple. Okay, so Steve, one of the questions that I would have for you would be around excellent work, a lot of work actually, to get to those 4 proteins. So you went ahead with IHCs, and obviously you had the antibodies to go ahead and do that. And given the challenges with IHC and the fact that it can be qualitative or subjective in one way, with +2s and +3s and +4s, given that you have mass spectral data, why not convert them into quantitative assays rapidly so that you could actually do LCM and make these measurements? And is that a path forward that you're thinking about, and how would that complement, for lack of a better word, with IHC?
Yeah, so thank you for raising that question. And it's obviously one that we've thought about considerably. I think there is a challenge in deciding how best to move forward with these observations. It took us a long time to get that data set, and it was done very carefully, and I haven't had time to describe in detail how carefully that was done in terms of annotating the images and having a database of all the images and where the sections are required from. So that's all been, there's a massive database of that, the experiment as well as the data from it. And how to move forward, I think, is really challenging. Obviously, MRM is one significant possibility that we've considered and are considering. I think the challenge for me in this project is thinking what we want as the clinical outcome and how that clinical outcome would be used. And it's not clear to me at the moment whether that would be by staining sections after biopsy, which is something that probably aligns better with a clinical path, or doing MRM, which obviously aligns better with some of the kind of quantitative proteomics that we like to do. And so I think we're very much in the position of trying to evaluate which is the best way to move forward. And so I think it's really good to get any comments and guidance that we can on that.
I mean, we're going to have to do IHC because that's the gold standard. So you're going to have to complement and demonstrate that these other proteomic-based measurements are going to actually complement really well. And in certain cases, you might have divergent results, as we have seen in literature before as well.
And
that could be quite challenging. And so, yes, it is a difficult task.
And I think the other biggest challenge, of course, is that just because we see a protein that is overexpressed in Gleason 3 epithelia compared to Gleason 4 epithelia regions, it's not clear that if we were to take a biopsy and take the section from the biopsy and homogenize all of that and do MRM, that we would necessarily, the data set that we've got will lead us, interestingly, to significant changes there. And of course, anything that involves LCM is not going to be a clinically viable test. I hope I've made that,
Great. Any questions? I see somebody standing over there. Yeah.
So, technical question relating to the samples. Can you give some indication of the biological variability between the samples, and also were they matched based on genetic factors such as age and such?
Yeah, that's a really good question, and you're probably not addressing it to the right person. There were 4 patient samples used here. They were, as far as I'm aware, they were closely matched by age. I don't think we've attempted to match them by genetic factors. They were part of a larger cohort of samples, and I suspect that we do have that data. It's just that we didn't use that to select these patient samples. It's a really interesting question in terms of fusions and the potential consequences of those. Yeah.
Thank you.
Thanks.
A somehow related question. In the design, did you consider, in your experimental design, did you consider power calculations and how you're proceeding, or this is really completely exploratory at this stage, and then later on you will design a study that has that type of considerations?
Yeah, so again, that's a really interesting question, and obviously this is not powered. This isn't a powered study. This is an exploratory investigative study, and I think what we try to do with all of these studies is to catch as many potential changes as possible, and then use subsequent studies to weed out those that are positive and genuinely positive. And I think that the powering then comes in the subsequent studies that we do, and having larger numbers of samples to do those subsequent studies. And ideally then, we would want to measure all of the proteins that we've discovered here and not attempt to prioritize based on immunohistochemistry or available antibodies. And so there's always, I think, this difficulty that we have, because if we prioritize on underpowered studies, we probably are potentially not prioritizing correctly. If we used MRM to measure all of those proteins, we wouldn't have to worry about that to the same extent, and we could do the powering in subsequent studies. Okay.
Great.
Thank you.
So let's thank Steve again. Thank you, Steve.